Great to see so many of you have stayed, and we've got our final session today, which has been alluded to a little bit today already, the role of transcatheter aortic valve implantation versus surgical aortic valve replacement. And we're going to have a nice little debate today, but to start with, I thought I'd just give a very brief overview about what we're actually dealing with and how we're assessing it before we go ahead and submit our patients to intervention. So the panel we've delighted to have Dr. Peter Tesser, who is an eminent cardiac surgeon. He's probably the most experienced cardiac surgeon in Queensland and has an enormous experience in aortic valve surgery in particular. He's the expert to go to if you've got a tough aortic problem, regardless of if you're a patient, a cardiologist or a cardiac surgeon himself. He will always be there to assist in the most tricky operations. And Peter's going to give us his perspective, which may be slightly biased from a surgical point of view with respect to aortic valve replacement, but it'll certainly be a very highly worthwhile opinion to listen to. Then we've got Carl, who's spearheading the transcatheter aortic valve implantation team here in Queensland. He's been involved in the highly successful St Andrews program, which is with the stats coming out of there with transcatheter aortic valve implantation are actually very, very exceptional. We're very happy with that, and that has been occurring with the support of a team which includes Peter Tesser as the surgical backup and Charles Chow, who's going to be doing giving us the CT perspective. Charles does a lot of the CT work with Johnny, evaluating these valves before they go to surgery or transcatheter aortic valve implantation, and he's often been involved in at the time, as myself and Damien Roper, Will Parsonage, during the transcatheter aortic valve implantation, assisting in identifying any issues, combining that in what we'll discuss a little bit, hybrid imaging, when we do the procedures. So imaging is a very important part of valvular heart disease assessment, and this is how we come to the decision as to whether or not a patient needs surgery. And if we look at valvular heart disease, we've talked about the prevalence. 13% of people over the age of 75 have significant disease. It's got a high morbidity, high mortality, and a high health economic burden. And if we look at Tom Marwick, who's an eminent Australian cardiologist who's been involved in a lot of the publications associated with imaging, he describes imaging as playing a critical and irreplaceable role in the assessment of valvular heart disease. It guides diagnosis, the planning of valvular intervention, the guidance of surgical and percutaneous interventions. Fusion imaging, it's a major advance. We can now combine imaging in the catheter lab with a CT scan, with an echo scan, overlay them and use that to guide intervention. And of course, very importantly, post-procedural follow-up, not only identifying the success of the procedure, but any complications or additional points that need to be addressed. There are a number of modalities when we're, and a number of things that we want to look at when we're looking at cardiovascular imaging. Firstly, valve structure and morphology, valve function, valve physiology, the pathology of the valve. Is it, for example, an aortic valve, a tricuspid, quadricuspid, bicuspid? And of course, the impact of that valve pathology on cardiac hemodynamics and flow, how it's affecting myocardial function. We were talking about that in atrial fibrillation, how important that is. And then, most importantly to the patient, their functional capacity. And there are a number of different modalities that we use. There's cardiac CT, PET scanning, echocardiography, MRI, and nuclear medicine. What's the priorities of imaging? We did have this star cardiac scientist here this morning. I think he's left already, Dane, has he? But Dane's one of our scientists. He's just demonstrating the useful ways a stethoscope can be applied to his work. And what we want to firstly identify is spatial and temporal resolution in terms of our priorities in imaging. It needs to be safe, accurate. The measurements need to be performed accurately. It needs to be portable. We need to be able to use that procedure for intraprocedural guidance. It needs to be accessible, patient-friendly, affordable. and minimise radiation. You can see a lot of patients are scared of going into the CT or MRI scanner, and that's where echo does actually have an additional role. And of course it needs to be reliable and reproducible. When we look at echocardiography, that's been the main type of imaging we've used for decades now, and echo has the benefits of now having not only 2D but 3D and 4D imaging. We have the additional option of transesophageal echo, where we pass a probe into the patient's stomach, take pictures from behind the heart, from within the left atrium, so we can see into the left atrium a lot more clearly. And of course we can do transesophageal echo in 2D, 3D and 4D. In some procedures, particularly ASD closure, for example, intracardiac echo can be utilised. And then we have stress echo, which is a great way of assessing valves and the impact on the patient. With echo, we can look at additional factors. We can look at aortic root pathology, very critical when we're considering TAVI versus surgical aortic valve replacement. If there's aortic root pathology, we've really got to go move to surgery. Valve physiology, we can measure things like the degree of aortic stenosis in aortic regurgitant lesions, the regurgitant fraction. We can measure cardiac function, and certainly 3D and 4D has markedly improved our ability to accurately assess cardiac function. We can look at myocardial reserve, for example, patients with severe mitral regurgitation or aortic stenosis, whether or not they're starting to develop cardiomyopathies related to their valves and whether or not they have some evidence of early dysfunction. And we can also look at valves and their suitability for repair or surgery, and that may come down to the degree of calcification on the valve. In mitral surgery in particular, it's very important at identifying which mitral scallops are affected and which ones need to be addressed, for example, in mitral repair surgery. But our focus is on aortic stenosis, and of course it accounts for just about a third of all native valve disease, and it's the third most common cardiovascular disease. It's important to mention that aortic valve calcification is an inflammatory process. It's influenced by genetics, but also hemodynamics and endothelial damage. So the older you get, the more risk factors you have, the more likely you are to have aortic stenosis. The lipid penetration into the valve increases inflammation and fibrosis and subsequently calcification. And that's why there's some theories, but also a little bit of data suggesting, for example, with PET scanning, that if you address patients' cardiovascular risk factors, including their lipids, their hypertension, you can reduce the rate of progression of some of this inflammatory process. The problem with aortic stenosis is that there's a long latent asymptomatic period, and the main predictor of survival is actually the gradient across the valve. So that's why we do serial screening in people with aortic stenosis. When they arrive to you with symptoms, that's when they certainly already require intervention. And that symptomatic triad is all well known to you: angina, heart failure, syncope. And then, of course, the clinical events are associated with a rising mortality, and obviously these patients will have a higher risk of other comorbidities the older they get. But echo is the gold standard in diagnosis and evaluation to inform the timing of intervention. And this is where patients will come to us and will identify that they have aortic stenosis, and we'll suggest that they come back in a year for another scan if they've got moderate aortic stenosis. And when it's mild, we might say 2 years, but we tend to like to monitor these patients, and the more risk factors they have, the more likely their disease is going to progress more rapidly. Now, what are we measuring when we take echo and images? And we're actually, essentially, with echo imaging, when we're assessing a gradient, we're looking at the change in pressure gradient across the valve here, and we use basically a formula continuity equation where we measure the outflow tract and the gradient across the outflow tract, and we compare it to the gradient across the most narrow point of the valve, and a comparison of that gradient can allow us to calculate the aortic valve area and make fairly accurate predictions, not only about stenosis but also about the aortic valve area itself. So that's the gradient, the formula that we use: A2 equals A1 minus V1 over V2, and that's what we're measuring across the aortic outflow. And we now have very well-defined categories of severity. It used to be, when I was a registrar, 50 millimetres of mercury, but now a mean gradient of 40 millimetres of mercury is acknowledged to be severe, and that's because we've been able to detect latent early changes in left ventricular function in these patients when they start getting gradients above that, but also mortality differences. We talk about an aortic valve area of less than 1 centimetre squared now being severe. Someone mentioned this morning it used to be 0.75, but now it's less than 1. And an indexed aortic valve area of 0.6 and a velocity ratio of less than 0.25. The aortic velocity of greater than 4 metres per second. So these are all our criteria for what constitutes severe aortic stenosis. You will have heard a little bit about patients with low flow, low gradient aortic stenosis. So some people have poor ejection fractions and other people have stiff hypertrophy ventricles that can't create a good flow across the valve, and they may have lower gradients, but in fact severe aortic stenosis. And we can often elucidate which of these patients actually do have severe aortic stenosis by doing things like stress echocardiography and see what the gradient is. Now, we have correlated this data, so this is all very solid data with cardiac catheterisation and in vitro studies, also with MRI. And I think the data we have on aortic valve gradients is now very solid and reliable, so we're using good criteria. We also, with echo, like to measure across the aortic root. We look at the left ventricular outflow tract, the transsinus dimension, the sinotubular dimension, and the ascending aorta, and these measurements are used when we look at patients with bicuspid valves, for example. Once the transsinus dimension goes over 45, we become much more likely to want to intervene, particularly if they've got diseased aortic valve, and in patients with dilated aortic roots, ascending aortas over 50 millimetres, then we're certainly looking at replacing the aorta or the aortic root as well. And this is some nice imaging of echo imaging, including 3D echo, showing a trileaflet aortic valve, a bicuspid aortic valve, and here's a quadricuspid aortic valve. So nice to show the different morphologies of aortic valve stenosis. And then finally, I don't know if we can see that, it's a little bit brighter, but the 3D imaging has allowed us to basically do continuous tracking of the endocardial contour to allow us to get much more accurate assessment of left ventricular ejection fraction. And this correlates very well with MRI data as well, with MRI perhaps a gold standard, but not everyone can tolerate an MRI, let alone afford one these days. Now, the specific advantages of 3D and 4D imaging in cardiology include the fact that you can basically not only demonstrate pathology, but you can demonstrate pathology in time. It often gives you better correlation between valves and chambers, and particularly volume calculations, as I've mentioned. And sometimes in just one rotation, you can get a complete analysis of valve dysfunction. Now, if we look at the comparison of different non-invasive cardiac imaging modalities, you can see that they each have their advantages. And I haven't included nuclear imaging here because because of the radiation involved, and it doesn't really rate in particular, for example, assessing aortic valves. But echo has the advantage of being portable, very good at assessing morphology and left ventricular function. We can look at the MRI being very, very good in flow, left ventricular function assessment, and then CT having certain advantages in the field of view. Of course, it has the disadvantage of radiation, and so we try to combine these different imaging modalities to suit the patient and their needs and requirements best. And Charles will be talking to you a little bit more about CT, so I won't go into the role of CT, except to say that it is a very important modality in transcatheter aortic valve implant. It's used in all the patients, not only to demonstrate pathology, calcification, but also allowing important measurements to be made with respect to coronary height and where the valve is going to be implanted. So when they are doing the assessment, they're not only measuring the aortic root and aortic valve area, but they're looking at coronary height and where the best place to position the implant. You also get very beautiful pictures of the peripheral vasculature and the CT assessment, and that's obviously important when passing catheters up through the iliac arteries and the aorta. And this is just my point about fusion imaging, which is critical in the cath lab, where you can combine not only the imaging of the CT, but you can overlay, here's the CT, overlay with the imaging using angiography in the lab, so that you can position the valve very accurately with the data subset you have from the CT that you've transported up. And at the same time, in some cases, particularly those cases where they are anaesthetised, will use transesophageal echo to identify perivalvular leaks or complications during and after the procedure. This is a slide just showing the transesophageal probe here. Here you've got your transcatheter aortic valve implant, the wire going across the aortic valve. And here is a transesophageal image where you can see here's the atrium, here's the aortic valve, here's the wire going across the aortic valve pre-implant. And Carl will explain a little bit more about what happens. But I don't know if you've got this image, but here you can see there's the wire going across the aortic valve, and here you can see the valve being deployed. Wire still in the ventricle using rapid pacing. The transesophageal probe coming down to have a little look to see if there's any aortic regurgitation. So use of combined imaging modalities. So this is just a little bit of an overview of some of the imaging techniques we use. Afterwards, here we're taking the transesophageal pictures, looking for any perivalvular aortic regurgitation. And you can get some very nice 3D images as well. Here's a 3D transesophageal image with the wire going through the newly deployed transcatheter aortic valve. So we get lovely pictures that can assist the people doing the procedure in guiding how it's gone. And then finally, MRI has a role in assessing these patients pre and post, but particularly its role is in congenital types of aortic valve disease, where you can identify bicuspid valves, associated coarctations. It's great for flow imaging, and certainly has an additive role, particularly in those patients. We wouldn't routinely do it in the TAVI patients.